Welcome to everyone. My name is Alarcos Cieza. I'm unit head for integrated service delivery at the Department of Non-Communicable Diseases at the World Health Organization in headquarters. And I have the pleasure and the honor to be a co-moderator today on this session on primary health care to advance health and disease-specific objectives. And I have also the pleasure to give the floor to my co-moderator to introduce himself.
Thank you, Alarcos. My name is Gerard Schmets. I am the Deputy Director of the Special Program on Primary Health Care in the WHO headquarters in Geneva. So we work in close collaboration, and we are very happy today to have all of you to participate to this panel 2A, to plenary 2A, sorry.
Great. And we have three objectives today. The first one is to learn. The second one is discuss. The third one is reflect. To learn from the virtual roundtables that took place before this conference on the same topic, on how primary health care can advance health-specific objectives and also disease-specific objectives. We will then discuss with a wonderful round of panelists, and then thirdly, we will reflect on what are the push and pull factors that contribute, that bring us closer and make us to advance towards primary health care, and those who push us away. We have a great challenge ahead of us because we are staying between the lunch. So we need to be very effective and communicate very shortly, because not only we stay between now and the lunch, but we also are starting a little bit later. So we need to really be effective. But without further ado, let me also remind that we will start with the learning, the first part of the session, with a presentation. Then we will go to our panels, to the discussion, and then at the end of the session for the reflections, we will also have a plenary keynote presentation. And without further ado, I pass the floor to you to introduce our first speaker, keynote, and for the learning objective.
Thank you very much, Alarcos. If we are all here today, I presume that you all know that before this conference, this international conference, we had a number of virtual roundtables. And we had a second roundtable on 20th of September, during which we discussed integration. And at the end of this session, we had a couple of asks to decision makers. And I would like to invite our friend and colleague, Dr. James Fitzgerald, who is the Director of Health Systems in the PAHO office in Washington, D.C., the WHO AMRO, but also the PAHO office, to present to us a couple of slides to explain what were the conclusions of this virtual roundtable. James, you have the floor.
So a very good afternoon to you all. I have the pleasure of presenting for you a few slides on the outcomes of a very lively and engaging virtual roundtable that we had during the midst of UNGA, actually. So it was many people from across the world fully engaged as the discussions around the Universal Health Coverage Declaration were ongoing. Next slide, please. So the purpose of this virtual roundtable was to really examine the opportunity that primary health care presents as a platform to advance our overall health and well-being objectives while ensuring the effective integration of priorities in the control and management of diseases. As you can see, it was the second virtual roundtable that was organized amongst the four that encapsulated really discussions from realizing the dream of Astana right through to primary healthcare policy. But this was really focused on how can we really utilize and leverage the primary healthcare platform to address the specific burden of disease that is prevalent across the world. We had discussions around 6 critical areas, from strengthening early childhood development, to NCD control and management and mental health, to strengthening the early detection of diseases from HIV, TB, malaria, other communicable diseases, and of course, NCDs. Critical to this was also looking at the issue of reproductive, maternal, child, adolescent health, and immunization services. We carried out a number of polls during the actual event. And the first question we posed to the audience was, how do we advance health and disease program objectives through primary health care? And it was very interesting to see the responses of the audience in this regard. It was not so much focused on empanelment and clinical guidance, but what we really saw from the audience was a message that is really reoccurring from this conference. It's around how do we develop the multidisciplinary professional teams, the competency-based approaches that are required to address the comprehensive needs of people? How do we improve those competencies in general practitioners and nurses, and indeed other health professionals? And how do we ensure then the strong referral systems that need to be put in place from the primary care through to more specialized care services? In a second poll, we asked the question, what are the most critical enablers to achieve this? And the obvious answer was more health workers. And that is fully justified. But I think what was really interesting to see was how we shifted from the lens of health workers into health financing to say we need to be able to shift from vertical programs to more needs-based, adjusted per capita financing to address the needs of primary health care and to increase health financing and improve financial management within health systems. The other areas that were of focus were around innovations in digital transformation of the health sector, in big data, and interoperable health records. While, of course, we did also discuss and see the relevant prevalence of leveraging the knowledge and capacity of international partners and experts globally to this agenda. So a couple of comments on the major asks towards the policymakers. 3 major asks were made in this regard. The first major ask was to strengthen the life course approach within health systems based on primary health care, but fully integrating disease program objectives. This essentially means that we need to recognize the differentiated needs of people, women, children, adolescents, men, adults, and older persons during the different stages of life, recognizing that the health needs of people are determined by their living conditions in cities, peri-urban areas, rural areas, and where they live, by the economic opportunity and social policies that influence individual and collective development, and that through early detection, health promotion, diagnosis and treatment based on the strong foundation of primary health care, we can improve the health and well-being of people during the journey of life, where our needs are continually evolving. Integration of care needs to occur at multiple levels. Levels of the healthcare system, ensuring continuity. Across disease programs, recognizing the coexistence of multimorbidity and health conditions that people present. And across the life course, promoting healthy aging at all stages of life. The second ask towards policymakers related to strengthening the capacity of interprofessional teams within primary health care, responding to the needs of people where they live. Here it was recognized that bottom-up planning in municipalities and health authorities and health territories means understanding the health conditions of the population where they live. It means designing the service offer around the needs of the community, and thereafter ensuring that the health teams we have in place, from community health and social workers to doctors, nurses, pharmacists, physiotherapists, and others, work collectively, providing team-based care to improve the health and well-being of people. This means new competencies, and new competencies are being asked of our health workers, from care coordination, health administration, to digital literacy, while we continue to strengthen the soft skills that are so required to humanize person-centered, compassionate, and empathetic care. The way we educate our health professionals, our health workforce, needs to be fully rethought. Firstly, promoting greater interdisciplinary education and training across professional competencies. And secondly, building capacity in collaborative practice and lifelong learning processes with incentives for specialization in primary health care. Lastly, the major ask was increasing public financing in health, reducing out-of-pocket expenditures, especially for medicines, and strengthening governance and oversight of policies and frameworks for primary health care. In health financing, there is an obvious need for more and better health financing for primary health care. Primary health care is the most effective and efficient way to provide comprehensive care through disease prevention and health promotion strategies and through early screening and diagnosis. However, countries continue to underinvest in primary health care while prioritizing hospital-centric models of care that are costly and inefficient. The health and economic argument needs to be made for primary health care and made more effectively to executive and finance branches of governments. Increased allocations for modern community-based primary care centres, in integrated health networks, in specialised primary health care workers, in mental health services, and in digital transformation will yield important health and economic dividends, and ensuring efficiency through better financial management and performance evaluation can reinforce the argument for additional financing for primary health care. At the same time, the progressive elimination of out-of-pocket expenditures ensures the financial protection of our people and of households, reducing the risk of impoverishment. In addition, increased investment in primary health care is essential to increase the resilience of our health systems, strengthening disease surveillance, acting as an early warning system for future global health outbreaks, global disease outbreaks. Investments in newer medicines and technologies and digital transformation can accelerate our efforts in disease elimination and control and begin to tackle the enormous burden in NCDs and mental health, reducing avoidable mortality. In this virtual roundtable, finally, we heard calls for better leadership and governance in health and other sectors, vertically and horizontally integrated, addressing the social determinants of health. Building health systems based on primary health care requires engagement of the community. This is something we know. But we do not appreciate that primary health care also brings benefit as it builds communities and solidarity within the community. We have much to do here, and so recognizing the cultural diversity of people and communities across the globe, differentiated strategies are required to ensure the greater engagement of people and communities in health, while social participation of health requires greater formalization in our societies. This is an issue that will be taken up by the World Health Assembly next year. Finally, the virtual roundtable provides us with this wonderful space to reflect on these issues. What behooves us now is to translate these recommendations into action at the national, subnational, and local levels, and really to ensure that we continue to mobilize the international community in the quest to achieve universal health coverage through primary health care. Thank you very much.
Great. Great. Thank you, James. Absolutely fantastic to set the stage in that way. We are coming now to our second objective and second part of this session, that is the discussion and reflection on this, on actually this recommendation, these topics and beyond. I would like to start by introducing our panelists, and I will go from left to right, but I would like to ask them, when I introduce them, to stand up so that we make sure that everyone sees you also from the back. So first, we have Artjoms Ursulskis, Parliamentary Secretary of the Ministry of Health in Latvia. Thank you. An applause, exactly. Secondly, we have His Excellency Alexandru Rafila, Minister of Health from Romania. Fantastic. Thank you for being with us. Third, we have Joe Keatinge, Senior Advisor from Foreign Commonwealth and Development Office in the UK. Third, we have His Excellency Alimkadyr, Beishenaliev, Minister of Health of Kyrgyzstan. Fifth, we have Taru Koivisto, Deputy Director General from the Ministry of Health of Social Affairs and Health in Finland. Welcome. Next, we have Tolunay, Deputy Minister of Health from Turkey. Welcome. Then Viorel Soltan, Team Leader at the Stop Tuberculosis Alliance. And last but not least, we have Marco Greco, President of the European Patients Forum. Welcome to all of you. To this panel, and I would like to immediately start with His Excellency Alexandru Rafila, Minister of Health of Romania. And Romania is undergoing a very ambitious reform in primary health care. Can you elaborate in not more than 4 minutes what are the key 3 strategies that you have put in place in this reform process? Thank you.
Thank you very much. Thank you. First, I want to congratulate and to thank government of Republic of Kazakhstan for hosting this important event of the Regional Committee of WHO Europe. And then I want to thank you to have the opportunity to be part of this important panel, because as you mentioned, our previous colleague presented the key messages and the strategic framework for the development of primary healthcare services across our region. For sure, the improvement and the development of primary healthcare is the key for universal health coverage and the real and easy access to health services in the next year. And I'm glad also to mention that Romania has a partnership, official partnership of Regional Committee of WHO regarding the implementation of the reforms of the health sector, and we have to finish in the next 2 or 3 years to have a new approach regarding the health services, because in Romania, like in many other countries, we have this let's say, traditional cultural model to hospital-based health services, and we have to change it, because to have better services close to patients and close to community is a normal approach. And I should mention, because I have only 4 minutes, that we started in 3 important fields. The first one is the prevention-based health services in the primary healthcare sector, and we changed the regulation regarding the way of payment, and we give incentives to primary healthcare practitioners to be deeply involved in this preventive programs and early detection of diseases, screening of cervical cancer, of breast cancer, of cardiovascular and cerebrovascular diseases, and the results, we started to see the results after a few months after this technical decision, which is also not only technical but also financial decision. And I think that there are real perspective to change model in giving health services in the primary from treating to preventing or early detection of diseases. The second important things we are doing is investment and training in primary health sector and expanding the capabilities of primary healthcare professionals in exploring the patients, in having a more precise diagnosis and having the right to prescribe appropriate treatment regimen. It's one of the needs, and we invest in more than 2,500 GPs wards in whole Romania, and we are waiting to finish this project of investment and also training, working together with their professional associations. And the third one, which is maybe one of the most challenging in some areas, especially in rural areas, in small towns, communities, is partnership and involvement of local authorities. Attracting a health worker, especially in such areas, it's not only a matter of money, it's a matter of how the community, how the leaders of the community understand the needs of the community in the health field. And we have good practice models developed in some rural areas in Romania. And what we are working very hard is to extend it and to have a real partnership for the organization of the villages in Romania, because we still have some hundreds of villages in Romania without access to primary healthcare services. And another issue, and I will stop soon, is to develop community-based primary healthcare, and not only primary healthcare, it's also with a social component, with some other preventive medical services which are given, and to try to extend the capabilities of these centers to more than one locality, or to more than one village or one small town, and to respond to the needs of the patient in that area. Thank you very much, and I don't want to have a longer time. Thank you.
That was great. You gave us really four: regulation and financing, then training of professionals, then involvement of local authorities and community services. Thank you so much for that.
Thank you very much. And now we are going to move to Kyrgyzstan with our special guest, Dr. Alimkadyr Beishenaliev. And Dr. Beishenaliev, we would like to hear from you how you have been successful in implementing village health committees and how these village health committees have allowed Kyrgyzstan to really put in place a primary healthcare strategy. Dr. Beishenaliev, you have the floor.
Спасибо. От имени Министерства здравоохранения Кыргызской Республики я от себя лично приветствую участников международной конференции «Политика и практика в сфере первичной медицинской санитарной помощи стремится к высоким результатам», посвященную 45-й годовщине принятия Алматинской декларации и 5-й годовщине принятия Астанинской декларации. Позвольте также выразить лично благодарность за приглашение принять участие на этой конференции, организованной правительством Республики Казахстан и при участии Европейского регионального бюро ВОЗ и ЮНИСЕФ. Мы высоко ценим роль данной конференции как эффективной платформы для укрепления нашего сотрудничества в области здравоохранения и выражаем надежду на дальнейшее плодотворное сотрудничество. Кыргызская республика в силах работы по укреплению здоровья населения с 2002 года была реализована программа действия сообщества по вопросам здоровья. Эта программа является партнерством между местными сообществами и государственной системой здравоохранения, в рамках которых впервые были созданы сельские комитеты здоровья, состоящие из волонтеров для работы по улучшению здоровья местного населения и взаимодействия с медицинскими работниками первичной медико-санитарной помощи. На сегодняшний день в масштабах всей страны функционирует 1700 сельских комитетов здоровья с более 25 тысяч членов, что охватывает более 80% сел Кыргызстана. Сельские комитеты здоровья имеют устоявшийся положительный имидж среди населения и демонстрируют потенциал влияния самих людей на условия жизни, определяющие их здоровье и благополучие. Как известно, система здравоохранения, независимо от степени развития, лишь на 25% влияет на состояние здоровья населения страны. Остальные 75% – это детерминанты здоровья, выходящие за рамки возможностей медицинских работников, но определяющие качество жизни человека. Миссия сельского комитета здоровья была определена как помогать людям быть здоровыми. Деятельность сельских комитетов здоровья направлена на изменение поведения людей, их образа жизни путем проведения информационных и просветительных мероприятий среди населения по профилактике неинфекционных заболеваний, вопросам питания и йододефицита, улучшению детерминации здоровья и другим аспектам. Ассоциация сельских комитетов здоровья делает посильный вклад в достижение поставленных страновых индикаторов. Реализовано около 20 средне- и долгосрочных межсекторальных проектов. Это профилактика эхинококоса, бешенства совместно с Министерством сельского хозяйства, продвижение прав мигрантов по доступу к медицинским услугам совместно с Министерством труда, сельского обеспечения и миграции, по детерминантам здоровья сельских сообществ с органами местного самоуправления. Сеть сельских комитетов здоровья является действенной платформой для широкого информирования и консультирования населения по вопросам здоровья. Она содействует профилактической работе первичной медико-санитарной помощи и вносит существенный вклад в укрепление здоровья населения. Таким образом, создание сельских комитетов здоровья стало основой для формирования и совершенствования межсекторальной политики в центре и на местах, направленной на улучшение здоровья населения. Деятельность сельских комитетов здоровья предоставила возможность первичной медико-санитарной помощи реализовать важные инициативы и подходы по прямому вовлечению сообществ в вопросы их здоровья, контроля детерминантов здоровья. В заключение хочу пожелать всем здоровья, благополучия и совместной продуктивной работы. Спасибо за внимание.
Thank you very much. Very good example on how we can really work in rural areas through the village committees. Long experience with a lot of success. Thank you so much. Alarcos?
Yeah, absolutely. And we go now from Kyrgyzstan to Turkey. And Turkey has done a lot of work on strengthening family medicine as the basis for primary health care, but also on integrating NCD and mental health services. So what we would like to know is that you share the experience from Turkey, putting accent on what facilitated the process of integration and strengthening family medicine, and what were the barriers, and how did you overcome those barriers?
Thank you, Alarcos. Thank you, Gerard. First of all, I would like to express my gratitude to the government of Kazakhstan for their warm hospitality and organizing this conference that's identified with Kazakhstan. I wholeheartedly believe that this conference will be an important turning point in the field of PHC and the global health, just like it was 45 years ago. What makes PHC indispensable is that it is easily accessible to everyone. In Turkey, PHC has been systematically implemented since 1960s. However, the turning point of PHC in our country was 2003. Thanks to the health transformation program, family medicine was introduced and PHC was brought to the modern standards required by the new century. In addition, the scope of the services under the PHC has been expanded, ensuring that services are provided in a holistic structure. In this way, the burden of the second and third step has been elevated and significant progress has been made in fight against preventable diseases. There is no doubt that mental health is an integral part of our individual and community health. In addition, it's an area that should be carried out on a community basis. We have adopted the principle of providing services with a person-centered approach focused on development, quality, and sustainability. Thus, our citizens can easily access mental health services. To this end, we integrated mental health services into the PHC and expanded its scope over time. We supported our health life centers located in PHC by employing psychologists, social workers, and child development experts. Again, we aim to increase the support we provide to our children and families in this field with the supporting the psychosocial development of 0-6-year-old children program. We expanded the scope of PHC by starting the fight against NCDs from family medicine units. To this end, we support our national family medicine network with our advanced information system. This continues to use the strength of our fight against chronic diseases. We facilitated the evidence-based diagnosis, treatment, and follow-up of our family physicians with the disease management platform and other digital platforms that we developed. Thanks to this system, we have developed a versatile modular system in our PHC services, especially for our aging population and to provide easy access to follow-up for them. Currently, hypertension, diabetes, obesity, cardiovascular risk assessment, and multidimensional elderly assessment modules have been activated, and our family physicians can perform standard screening and follow-up procedures of healthy, elderly, or sick people in the target group in the population registered to them by using these modules. They can effectively manage the process by creating a treatment plan for patients. In 2024, we plan to complete the coronary artery disease, chronic kidney diseases, stroke, and asthma COPD modules and make them available to our citizens. The lack of awareness our citizens about chronic diseases, the follow-up of these diseases, and the increasing workload have emerged as the most important problems. In overcoming these problems, increasing the awareness of healthcare professionals and attaching importance to the health literacy of citizens have been the most important tools that we have used. Thank you.
Fantastic. No, fantastic. And I'm sure that many of the participants will be willing to talk to you about this 20 years journey that you have now summarized in 4 minutes, but fantastic example. Thank you.
Thank you very much. Let's now move to Latvia with Mr. Ursulskis in the Parliamentary in the Ministry of Affairs. Mr. Ursulskis, your country has been successful in putting in place pathways between the primary care level and the other levels of care with regard to patients with chronic conditions and long-term care. Could you please elaborate a bit on that and tell us a bit about the success factors that have enabled this to take place? Thank you.
Yeah, thank you very much, and good afternoon, everyone. I won't be very original to actually thanking the host nation Kazakhstan for being here and conducting this wonderful conference. Really, thank you very much. Speaking about the primary care, I think that other participants in this panel would share the similar challenges we have in our countries. We often lack funding, we often lack equipment, sometimes we lack human resources, sometimes we lack progress in digitalization, etc. Latvia, unfortunately, is experiencing all of these problems, but However, I think that it's worth not looking only towards problems, but towards good practices, basically what we can do with the existing amount of resources and money. And of course, without any doubt, the GP or general practitioner's practice is the cornerstone of the medical system, because this is the place where people come first. This is a place where we can prevent diseases. This is a place when we can have initial first treatment and probably initial first diagnosis. So therefore, I will share some insight on how we are working in this field and how we found some quite effective and good pathways to growth in already existing process. So first and foremost, I want to highlight our work with the oncology patients. Oncology, very hard, very sensitive topic, which is still needs to be investigated, and a lot of things should be done to actually prevent and understand how to cure the disease. And this is the disease where extremely important is to catch the disease at the first stage. If you find that you are ill, you have much more chances to actually survive and have a good treatment and come back to full and good quality life. This was the priority for several governments in Latvia in a row since 2018, and we introduced a new structural system that ensures rapid diagnosis and treatment for first-time cancer patients. We call the system Green Corridor. So basically, in a short, patients are redirected to the so-called fast lane or fast track, as in the airport, and they should receive treatment within 1.5 months after the preliminary diagnosis is established at the general practitioner's practice. And general practitioners, they have strictly set rules of conduct. So basically, they have referral procedures, they have very clear criteria how to diagnose, and they know what to do next. And because of that, when the patient goes to the oncology specialists, they already receive patients that are properly examined, they had already their first treatment, and the work of those oncology specialists, therefore, is easier. And our legislation also sets deadlines for medical institutions that are controlled by state, financed by state. They have deadlines to provide specific examinations for certain diagnoses, as well as we have also deadlines for the tertiary care institutions that provide the final treatment if it's needed. And I should note that it took almost 2 years to successfully implement the Green Corridor algorithm. We monitored all the queues, we tried to evaluate the quality of all the procedures, had some feedback from general practitioners and also from the oncology specialists, and adjusted the system. 6 years passed. I suppose that the majority of Latvian society has been quite familiar with the system and knows the opportunities. Also, very shortly, some other smaller initiatives we are currently conducted at our general practitioner's office, several risk assessment programs for diseases such as cardiovascular disease. Also, during the COVID-19 pandemic, we understood that mental, emotional problems are on the rise, and that's why our GPs were very intensively involved in diagnostics before transferring the patients to the next levels of care. And also, finally, last year, in addition to the Green Corridor, we established similar one, the Yellow Corridor, but in this case, it was about recurring oncological diseases. This is mainly all for now, and thank you for listening, and I hope that our expertise and our ideas may help to other colleagues all over the world. Thank you.
Great.
Thank you so much, Mr. Ursulskis. You started by explaining to us that you don't have all the finance you need, but there are possibilities to innovate, to transform, and to make the life of the people easier through a reorganization of the services. Thank you very much.
Yeah.
Alarcos, let's go to
Great.
the next.
Yeah, let's go to Finland now. And I want to mention that Taru is the Director General of the Department for Communities and Functional Capacity, that I think already says quite a lot in the way how Finland has taken in an integrated approach for the delivery of services, focusing very much on functioning, on the everyday functioning of people as the center of the model of care. So we are really looking forward to hearing from you what is the core of this integration and what has been the main success factors. I'm sure you have them. Can you just a little bit closer, probably? No?
Yeah. So, first of all, thank you for having this opportunity to present our experiences here in this conference. For us, as you said, we have been rather successful, but however, a lot has happened and the world is now a little bit different compared to the history. So that's something which is also for us very, very important to have this opportunity to share views and learn from each other. I start from far from history, just shortly. One of the successes which is still the basis for our services in Finland. Already in the 70s, we were in a situation when Finland was not so highly developed and people were really sick, especially middle-aged men died early and the situation wasn't so good. So we started to develop primary healthcare and public health activities at the same time because care wasn't enough. We needed to prevent also and promote the health of the people. And what were the success factors? I'll mention three of them during this presentation. So first was political commitment and support of WHO, and that's the history where it started. And then I'll go into the organization of services and then financing. Three issues which have been already mentioned several times here as a priorities already this time as well. So going back to the 70s, we created a system with the support of WHO based on Almaty Declaration, which was an inspiration for us, to have primary healthcare and public health services provided for the whole country, for the whole population, covering everyone. At the beginning, it wasn't very broad range of services, but all the basic services were provided. Gradually, this has been increasing. More and more services are now part of that basic service package. So we started from the needs of the population and tried to create the services for all parts of the country, including the rural ones. Then about the second success, which is still very relevant, is how we organize the services. We have had for a long time multi-professional health centers, multi-professional teams, and there are several professionals working together, nurses, public health nurses, physicians, laboratory services, and rehabilitation. Nowadays also social services are included there, and psychosocial services, substance abuse services, so that all these are working together and they know the area and the needs of the population, and together they can find the solutions also. So that's one very big success, which I really find most important there. But also multi-sectoral approach is important there in the basic level in health and social centers, so that on local level there's opportunity to work with other sectors, for example, education, physical activity, urban planning, etc., to find common ways to work together and how to promote the well-being and health of the population. So the services are organized in centers, which are not always one building. It's more an administrative structure under which there are all these services working together but it's one administration, one budget, and so we are not struggling with each other, competing for the resources. So it's the entity which is taken care by the politicians and the decision makers. So, and also I mentioned also here the COVID-19, because it's something where we found very strong basis on this model. And then just now we are in a turning point. We don't know yet what's going to happen, because we just in the beginning of this year had a big reform of the whole system. It used to be for 40 years the municipalities, the local governments responsible for all this, which I just described. But now it's going to be regional authority, which is covering also hospitals and rescue services. So that in one administrative unit there will be all these: primary healthcare, public health, environmental health, hospitals, rescue services. Because we saw the development that hospitals and primary services were competing with each other, and that came a big challenge for us. And because of that, now we have just starting a big reform. We hope that it will help, because the priorities of this reform are emphasis on primary services, emphasis on prevention, promotion, and also emphasis on equity and effectiveness. So we look forward to a future. Then the third one, a success story about financing. It's something which is a success and also a challenge, because in the beginning we used to have earmarked financing for services, and gradually it was moved to lump sum of subsidies which were given to the local level. And now we are in the situation that the money, the subsidies are given to the regions. So we'll see how it's going to happen with the division of resources between these different kind of services. But all the time, for decades, there have been certain set of criteria for financing of public financing of services based on needs. Population, amount of population, age structure, areas, characteristics, is it rural or is there some special problems with mortality, morbidity, etc. So this still is the basis for financing.
And Taru,
But as
I
said,
think,
just shortly,
yeah.
One more issue. So I just want to emphasize that we should not look at only the history, but about successful we have been. We have to look at the future. Yeah. Reform. We have to reform ourselves.
Yeah, great. Thank you, Taru. An applaud, please. It's a great, really great example from Finland. 50 years of history and still working on it. What says a lot, and also bring really this perspective that is really a journey that always need revitalization. So thank you for that. And we will, for everyone, we will go over time. We started late, so we will take at least 10 additional minutes from your lunch break. Gerard.
Thank you to reassure us, Alarcos. Let's now move to UK, or I would say beyond UK, with you, Joe, who work in the FCDO in London, but also a lot in Africa. And we would like to get your views on how we can integrate vertical program, disease programs, into the health system, and more particularly, what are the push and pull factors for integration into primary healthcare packages. Joe, you have the floor.
Great, thanks. And I recognize that I'm standing between your lunch, so I'm going to shut this down very quickly. But I do want to thank the government of Kazakhstan for inviting us. I have felt energized for the first time in a long time, and it's great to be here at the fifth year's celebration of Astana. I'm not going to bore you with what FCDO does in terms of its integration and health system strengthening, because you can go on to the UK government website, because we outlined our approach in terms of the shifts we want to make in health system strengthening and integration. I'll mention a couple of things, because the President this morning mentioned some of the core principles that I think are really important to us, and need to remind myself that rights and equity and getting to those who are most left behind are so important, and it's what we strive to do in all of our work. We use all of our levers in FCDO. There isn't just one approach to tackling kind of strengthening primary healthcare. A lot's been said about the politics, a lot's been said about country-level ownership, a lot's been said about financing. And I think in FCDO, what we try and do is use our diplomatic networks, so please reach out to them. We use our technical expertise, as well as our UK institutions and academia to share our learning, but enter into debates. And then we use our overseas development assistance to support those countries who ask for our help. I suppose the biggest shifts that we're making are to try and get all of our investments to work better together, whether that's the multilaterals, whether that's our technical partnerships, whether that's our in-country presence, and that's complicated. Everybody has a different agenda. We need to, and we try to, listen. We need to sit down and coordinate. We need to get round country plans and priorities and be open, honest, and transparent. And that hopefully is the shift that you're seeing in terms of some of the FCDO's approaches. We can't do it alone. It's been a great couple of days to form more partnerships. But as the Minister, our Foreign Secretary says, we're in this for the long term, so let's work together in the long term towards the common goal. So I really enjoy all the learning, and thanks very much for inviting us. Cheers.
Thank you very much, Joe. Lot of hope. We hope that we can really make this integration a reality in the countries that are supported by your institution, but also other institutions, as it was explained this morning. Thank you very much, Alarcos.
And I think for those who knows you, saying that you have been energized again through this conference, the workshop yesterday, since a long time means a lot. So that probably means that you have seen a lot of progress. So good feedback. Now we move to tuberculosis and to Viorel, and also during the UN General Assembly we have seen the declaration on tuberculosis, and also the high-level meeting on tuberculosis with a lot of political commitment, but also through a push through radical reorientation toward PAC in the delivery of services for tuberculosis. So can you please tell us how a Stop TB partnership intends or is already moving forward this agenda of integration?
Thank you, Alarcos. Stop TB partnership is a UN-based organization that leads the fight of tuberculosis in the world. And thanks a lot for accommodating us in this important event. Thank you, WHO, UNICEF, but of course the government of Kazakhstan, Ministry of Health. We believe in-house that we can end TB by having a strong and well-set primary health care in the country, right? So talking about access to services, I would like to mention that in-house we have a global drug facility. We call it GDF. This is the largest mechanism, procurement and supply mechanism of the TB products in the world, through which countries and partners procure drugs and diagnostics for their use. During the UN high-level meeting in New York, Stop TB Partnership and USAID and the Global Fund and partners announced a big decrease of price having such mechanisms at the global level allow you to do a market shaping. So we dropped the prices for some drugs for almost 30%. And now the treatment and prevention of tuberculosis is more affordable, which is very much important, right, when we talk about access to services at the primary healthcare level. And it's very timely because these savings now are oriented to cover the gaps because all of us are applying to the Global Fund proposals, and those savings are very important to cover the gaps for other needs at the country level. Or I can give you another example in terms of having a specific drugs for children. Till recently, we were crashing these tablets, giving tablets for children. And now we came to specific doses and syrups, friendly syrups for children that we supply to countries. And I see the Minister of Health of the Republic of Moldova. Moldova is one of the many countries that we supply. And I guess this week we are supplying a portion of those drugs to Moldova as well. We miss 4 million people annually of tuberculosis for many reasons, but majority are those barriers that are linked to human rights, stigma barriers. We miss people to diagnose and treat. And this is very important to go and understand those barriers, but also to overcome those barriers. In more than 40 countries around the world, in all regions, we in high burden countries, we are working on digging inside and understanding those barriers and also transforming those assessments into action plans. So we recently published an interesting evidences which are first ever evidences around tuberculosis, how these barriers are affecting access to services. Talking about acceptability, services should not be only available or accessible and affordable, they should be accepted by those who use those services. We very little pay attention on feedback from people that use this. So I can tell you that in more than 27 countries around the world, we are instituting right now community-led monitoring, where people can provide their feedback around the services that we offer. This is very important to understand that feedback and so on. I know I have only 4 minutes and I have just one point to mention. Yes. New tools are very important, and we learned this morning about this. You know that right now we have X-ray machines which are not portable but ultra portable. It's like that video camera that sits there. It's just like that. You put and do X-ray, and not only you do it, but you can read it through the artificial intelligence. This is very important in bringing again services closer to people. And at the end, I just want to mention that we are believers that primary health care indeed can end TB. Yes, we can end TB with a strong primary health care.
Great.
Thank you very much.
Really great that you mentioned primary health care at the end, so because the word integration was missing there a little bit, but I'm sure we can discuss, and many others can discuss then also during the break. Let's move on to our last speaker, and I would say really not least, because it is the voice of patients. And we work for patients. So what are the 3 main asks that patients have to changing primary health care for the better? We heard something today in the morning. Please be brief now.
Thank you first of all for inviting us here. Thanks to the government of Kazakhstan and to WHO for having shown the willingness of having patients on the stage today in an important recurrence also. It's not easy to identify only 3 elements, so I would try to play a bit in the joints and to identify, let's say, 3 potential work streams on which we would like to focus. Because, you know, primary care is more than essential, is indeed the backbone of every healthcare system. It's where you start measuring if an health system is working properly or not. For us, it's not something we do work on, it's something we live every day and that we experience every day. So the first work stream is, I would say, coordination and continuity of care. It's essential that systems are not only accessible, that is the first thing, because you can have the best possible system, but if the patient cannot get it easily, it's not working, it's not true innovation. We need also continuity, and we need a system that is friendly to be used by the patients. Too often, we listen our members mentioning, you know, the expression, we need to fight the system. You need to be integrated in the system, and this is possible only if you co-design the system, if you go where the necessity is. In the recent proposed new legislation from the European Commission, we are finally focusing on patients' unmet need. This is a revolution, although we need to understand what it does mean, but it is for another Congress. It's also important that the system, as I said, has to be integrated. The whole healthcare system needs to work also with health and social care together, but also in a way that the patient's needs are put at the core, and it is not needed for the patient to run around, particularly when you have the necessity of multi-diagnosis or more exams. Somebody has to coordinate it in an efficient way. It cannot be the patient that should do that. The second thing is something that is really dear to me. It's patient information and investment in health literacy. It was mentioned also this morning. We need to keep informing patients. We need to keep working on education of patients because it's the first essential step also for avoiding waste in a system that cannot afford any waste. The third thing is shared decision-making and meaningful patient involvement and engagement. Engage with patients, talk with them, don't be shy in working with patients, because that is the key to success and to succeed in every reform we want to do on healthcare systems. As I said, this can be today a turning point for us if we want to develop something new, something concrete, something that can work. We have seen examples this morning also in this session. Working together can lead to incredible results and can unleash unbelievable innovation. Thank you.
Fantastic. An applaud. Clear and brief. So thank you for that. They asked for patience, very clear and brief. We will have to take an additional 10 minutes from your break. Hope it is okay.
Thank you.
And then we pass to you. Yeah.
Thank you. Thank you very much to all our panelists. And I would like now to invite our expert who will provide the reflections on all the innovations and ideas that have been provided today by our panelists. We have the privilege to have with us Professor Jan de Massener. Jan is a professor of family medicine and primary care in the University of Ghent, Professor Emeritus, but he is also the head of the collaborating center with WHO on primary care and family medicine. Jan, you have the floor.
So, ladies and gentlemen, I hope you are not too hungry. I will try to be as concise as possible. I think we have been listening to very interesting reflections by 8 different stakeholders on how primary healthcare could advance health and disease-specific objectives. They made it very clear that the heart of the debate for the future design of primary healthcare is the relationship between the PHC strategy on the one hand and the organization of primary care services on the other hand. And in principle, there are two different options, and we have heard that. The first is you start to develop vertical disease-oriented programs on chronic conditions, on infectious diseases, on mental health problems, and then you ask the primary care services and their staff to implement these programs. We know that this approach leads to different problems. The fact that multimorbidity actually becomes rather the rule than the exception, hence people have to comply with a multitude of non-integrated monodisease trajectories leading to fragmentation, sometimes to contradiction in diagnostic and therapeutic interventions and inefficient use of scarce resources. And we have seen how you can do better in the different contributions. Such monodisease programs may also lead to inequity by disease, as not all the programs offer the same basket of accompanying measures, for instance, access to certain disciplines, physiotherapy, but also in developing countries, access to food grants, to educational grants, and so on. And there is a second option, and that option starts from investing in the training and development of interprofessional primary care teams or primary care networks, including social care, that are accountable for a defined population, defined either by geographical, administrative criteria, or through a person list. Equity and access is of utmost importance and contributes to universal health coverage. These primary care teams are responsive to the health and well-being needs of the people and start their interventions focusing on the life goals of the patient. That means that we go for a paradigm shift from what's the matter with the patient to what matters to the patient. And I think that the need for this paradigm shift was echoed in the contribution of the European Patient Forum representative. This approach gives a new perspective to the care for chronic conditions, diabetes, heart failure, depression. By doing so, the primary care team will develop a continuous interaction with the communities and the population they serve, with special attention to vulnerable groups, putting into practice the core PHC messages of the Alma-Ata and the Astana declarations. The concept of the village health committees in Kyrgyzstan is an excellent example of this approach. In order to make this happen, the interprofessional team will continuously improve the quality of care, updating their knowledge and skills with special attention for the provider-patient communication, integrating appropriate, relevant digital tools when it's needed. I think that this second approach is what is the way forward, and it is happening in many countries nowadays, and we have seen some examples. The approach in Turkey, where family medicine was strengthened as a foundation for primary health care. It facilitated integration of NCTs and also mental health approaches. And then also the act of the Stop Tuberculosis Partnership illustrated how radical reorientation of health systems to our PHC can also make a difference for this program. Both for the care for the individual and for the population-oriented intervention, we need data. Well-structured, episode-oriented data coded with international classification for primary care or other classifications that are of use, they are the basis of integrated interprofessional electronic health records. And I think that was a common denominator in the intervention of many of these contributors. These data can be used not only in care for individuals, but they can also contribute to a community diagnosis, looking with the community at the upstream causes of ill health, integrating social determinants, poverty, literacy, income, ecological determinants, commercial determinants, with special attention for groups like migrants, refugees, homeless people, disabled people. This approach is known as community-oriented primary care, and it's one of the strategies that contribute to the integration of PHC and public health, an important goal as we learned from the examples from Finland and in Romania, where prevention was integrated in primary health care. The positive impact of primary care services when they have a gate opening function and not a gatekeeping function on the utilization of secondary care is broadly documented. We heard interesting example from Latvia, creating fast pathways between primary care and other levels of care. Recently, there are indications that probably the impact of PHC should not only be measured within the health sector. maybe one of the most important societal contributions of PHC is that it seems to be related to more social cohesion, through its focus on equity, on the person and his or her life goals, and on the community in the broader context. I think that nowadays, social cohesion is what policymakers need most, as it is an essential requirement for any societal project. It will be interesting to wider explore the contribution that PHC can make to social cohesion. I see opportunities on how political developments could further contribute to the acceleration towards stronger PHC. First of all, as has been said, more resources should go to PHC. In OECD countries, actually on the average, 14% of total health expenditures go to primary care services. Taking into account the actual demographical and epidemiological transitions and the increasing tasks for PHC, this percentage, in my opinion, should be doubled up to 30% of the total health expenditure by 2030. Second point, in low and middle income countries, it is important to invest in primary health care, but there's a problem of resources. So increasing resources should be put into education and training of the primary care professionals, community health workers, nurses and family physicians, pharmacists, cooperating with social workers. But important to get that money in the primary care, I think that a shift of resources from vertical disease-oriented programs towards comprehensive horizontal primary care services is urgently needed. In 2020, we proposed in an article in the WHO Bulletin the 30 by 2030 campaign, asking that donors invest 30% of the budgets of their vertical programs in the development and strengthening of local primary care services. We learned from Joe Keatinge how disease-specific programs can be integrated into health systems to better align funding with national PHC strategies, and I think that's very hopeful news. Finally, we also can look at the way WHO itself is organized. It is positive that there is a special program on PHC, it's working very well, and that the Universal Health Coverage Partnership is integrated in this program. But should a special program on PHC not rather be the central overarching program interacting with the existing technical programs on infectious disease, on NCDs, on mother and child health care? It's just a suggestion. In conclusion, there is a lot of positive developments ongoing in member states, but commitment and action is needed because everybody counts and no one should be left behind. And to make this happen, we need to focus on two important building blocks. As the Belgian Federal Minister of Health, Frank van den Broeke, recently said in a speech, to make the change happen, we need to build on science and solidarity. Thank you very much.
Thank you very much, Jan. Very clear. I think that we know now what we need to do. And Alarcos will explain to us.
And actually, I would suggest, if you agree, that we take Jan's summary as the final words and summary of the session so that everyone can go for lunch, because we will have to come back exactly at 3. I think what you can really see, or what you have seen, is really great examples. Everyone will be here during the lunch break. You can really talk to whatever you have with the persons that you have heard and really get more information. And I think we should close the session now. What do you think?
Absolutely. Bon appétit, all.
Bon appétit. Thank you, and applaud for all the